In this video, a multidisciplinary team from the Providence Cancer Institute in Portland, Oregon discusses how they started a thriving community-based lung cancer screening program. How did you start the Providence Lung Cancer Screening Program outside of an academic setting?
Back in 2011, when the National Lung Cancer Screening Trial results were published, which showed a 20% decrease in mortality in patients who underwent lung cancer screening with CT, we realized at our institution that this was going to be a very big thing and that we wanted to get a jump on being a leader in our community with setting up a lung cancer screening program. And so there were several of us that put our heads together and started building the program.
Our multi-specialty team began to meet to discuss and discern how we would wish to work together to create an organized program to recapitulate the program in an LST. There again was significant doubt expressed by the critics of lung cancer screening that this would not be something that could be reproducible outside of an academic center, and there were concerns that there could be increased complication for patients undergoing lung cancer screening outside of academic settings. And for a non-academic center, that was something that was a little frustrating to hear when we have an organized multi-specialty program. And so our goal was to look at and see if we could indeed recreate that type of a screening program in a community-type setting.
Could you describe your decentralized screening program?
The Providence system covers multiple hospitals and multiple outpatient clinics and outpatient imaging centers. And so we realized that we probably needed to have what we called a decentralized system versus a centralized system. With a centralized system, everything's kind of under one roof. You have sometimes a nurse navigator or a program coordinator who takes the patients in, does the shared decision-making, makes sure they're eligible for screening. And then the patient, actually that same day, will often get their CT scan. They'll go over the results. We were not in a situation where we'd be able to do that because of all the sites that we have.
So our program is made up now of 10 imaging facilities. Most are at hospitals. We have 2 large tertiary hospitals involved in the program, and we have 5 outlying hospitals. So the goal was to provide the widest net possible to bring in screening patients even in these more outlying areas. It was important, though, that we had designated radiologists review these, and that if there were questions or problems, that there still was a central authority or location where the results could be reviewed and we could make sure that there was appropriate management of these patients. I think the importance of it is that we do have a central location per se to review more difficult cases and to make sure that the management of even these outlying patients is appropriate.
What are the most important aspects of your screening program?
There's really 5 things, in my opinion. First being is that you really need to have the administrative support behind you. You need to have people involved with the process who share in the financial decision-making. And that's because you're going to be reaching out to your administration and asking them for resources, including staffing, maybe equipment. The second big thing is that you really need to have a multidisciplinary committee composed of different medical specialists, because lung cancer screening, it's not just a CT scan. Treating lung cancer involves multiple different specialists, which include thoracic surgeons, pulmonologists, oncologists, radiation oncologists, pathologists. So it's really critical to have multiple different specialties on board because radiologists can't do this in a vacuum by themselves. The third thing is that whether you have a centralized or a decentralized program is to have a program coordinator, someone who is sort of the hub of everything within the program. And then the fourth major thing is you really need to have a database for patient tracking, for patient follow-up, and to be able to monitor your results and outcomes. And the other reason you need a database is because currently you need to be able to upload this data to the ACR registry. And finally, within diagnostic imaging, you need to have policies and protocols in place for your imaging infrastructure, for the scheduling, the actual scanning of the patient, standardized patient reporting, and then for patient follow-up.
You engaged primary care from the beginning. How did you earn their trust and support?
They were engaged from the beginning because they're the primary stakeholders in all this. They're the ones that are the front line on lung cancer screening. And we always kind of viewed ourselves as they were our customers, the patient and the primary care physicians. As a matter of fact, the primary care leadership was skeptical of lung cancer screening at first because they were worried about a bunch of specialists, proceduralists pitching a program to them. But the membership of the primary care community had already read the prospective randomized study and translated into clinical practice, so they kind of dragged their leadership along with regard to the endorsement.
All along, we've used national guidelines for how we follow patients in regards to nodules and frequency of follow-up, and so forth. We've carefully recorded patients' findings, complications, and have published and made sure that referring provider base was aware of our results so that they would feel comfortable with the program and continue to refer patients.
There are benefits and risks to lung cancer screening that patients need to know. Where does shared decision-making occur in your program?
Documentation of shared decision-making is one of the requirements for a lung cancer screening program. And initially for our program, this was documented and the shared decision-making was conducted through our program and our program coordinators. We felt that it was critical to discuss both the risk and the benefit of lung cancer screening so that patients had proper consent and understanding of both those risks and benefits from undergoing CT screening and potential follow-up of findings after they underwent screening. As support grew, then the primary physicians who were referring patients felt more comfortable with the concept of lung cancer screening as well as with shared decision-making. And because of the regularity of referrals, they wanted to take back ownership of that shared decision-making process. In our opinion, that was really the proper place for the risk-benefit discussion in the first place, is with the physician who is making that primary referral, taking that primary management, and managing proactively the care of their patient.
What practical advice do you have for centers that want to start or optimize a program?
If you're going to start a program, you need to have a champion, better to have a team of champions, better if that team of champions is already an experienced team. We were lucky with lung cancer screening that we already had a really well-oiled thoracic oncology program. So we already had a long history of sort of working with multiple specialists together to do common disease management that was evidence-based as much as possible.
You need to have individuals from all the different kind of components of care that are interested in doing this. You need an institution that wants to make this a priority, and you need the multidisciplinary providers who are going to have a stake in making sure that the program works, that it provides adequate care for patients, and in the end, achieves the goal of finding early lung cancers and treating them appropriately.
Look for other episodes from TOPS that highlight practical perspectives in managing lung cancer.